This is a really, really cool procedure. One of the things I love in the interventional pain space now, we're getting to where we can not only begin to impact patients' lives and influence their pain before it becomes a huge issue. We can actually treat it instead of just covering it up. And the neat thing about the eloquence of this procedure is that you're dilating everything. You're not actually cutting tissue. You're not destroying tissue. You are literally distending it out of the way for us to be able to get this implant in. So it's really, really cool at the end of the procedure when you pull everything out, all the tissue just comes back together.
Yep.
Everything lays. It's amazing.
I was amazed by the blood loss. The first.
It's pretty minimal.
It's almost nothing at all because of that.
Yep.
You know, you irrigate the wound and then
There's nothing.
there's not much at all.
Yep.
You
There's
don't need
nothing.
pressure.
Got a 1-inch incision on the side, and
Yeah.
go. You do your thing. You teach.
Sorry.
This is so exciting. You,
I'm
you
excited
and I
about
want to
it.
take over.
Why the lateral approach for this is we're able to spare a lot of the anatomy with it. We're leaving the multifidi muscle intact. We've already talked about that a lot today. We're leaving that supraspinous ligament intact, and we know that that leads to a lot of adjacent segment disease. If we're able to leave that stabilized, patients do so much better. The fact that we can go in and not do any of that and still get a really, really strong fusion. I love this CT scan here because it actually shows the fusion in between the two spinous processes sitting in the middle of the implant. On that implant itself, we've actually packed the middle portion with bone graft. So once we deploy those wings, that bone graft fits right in the middle of that space.
If you're out there and you want to help your patients, I mean, this is an amazing way to get that fusion, like we showed in that CT scan, without destroying everything in the back. You only get one back. You're taking it with you. There's knee replacements, there's hip replacements,
Yep.
Nope.
there's shoulder replacements, there's no back replacements.
This procedure is unbelievable for patients who, one, don't want a huge big fusion, don't want 3 months under the weather, so to speak. So for those patients, this is amazing. Also for those who medically may not be able to tolerate that big, huge surgery. They can't tolerate that length of anesthesia. To me, it's all about patient selection. Are they not a good candidate for a bigger open procedure or something from the posterior
We're
aspect?
actually really good at this because we're so good at fluoro. It's all done under fluoro. Once you place this pin perfectly, that's when we're there, and that's when we're good.
That it's all about patient selection. If it is a patient that doesn't want that bigger surgery, they're not going to be at that surgeon's door anyway. If it's a patient that medically can't tolerate it, the surgeons aren't going to want to take that to the OR. And honestly, our patients are becoming more and more educated to where they're seeking this out. They're seeking the minimally invasive procedures out. They're seeking different care out than just going and getting cut on. So to me, I think it's sitting down and having that conversation. Hey, here's what I can do. Here is why we do it. Here are some indications of why we do it. What do you think about it? And honestly, the surgeons that I've talked to about it have all been very open.
Yeah.
Very. In fact, a few of them have wanted to come get trained on it.
Yeah,
No,
they do.
I think that's what's happening.
Yeah.
That I've seen is they say, well, we can do that too. It's like, yeah, you can. And that's what it's all about, is helping patients all over. It's good to see when new techniques come out in our field and the surgeons say that, exactly what you said, that I want to get trained on it too. That's when you know it's going to take off.